So, of course, I have a conflict of interest with this presentation. It was a very opportunity for me to welcome Hala and the GE team 2 years ago before the Olympic Games, as you can observe on this slide. And I'd like to thank General Electric for the help for the visit today and to help me to perform a big study. And for the next slide, I will show you the study. So this is the plan of the presentation. First, probably my institution. So I came from Nîmes. Nîmes is a very small city in south of France. Probably you know the name of Nîmes. Nîmes was built by the Romans. And you can observe on this slide 2 historic monuments. First one, the arena, for a concert in August and July, music, Dua Lipa and so, if you know Dua Lipa, and a temple in the center. So it's very nice place. And I invite you to come to see this city. So what about my hospital? This is, as I said, digital hospital. You can work without any paper, without any pain. My team, 48 consultants and residents. This is a university hospital. We perform more than 25,000 surgery every day with large of obstetric and other surgeries. This is non-surgery. This is for endoscopic cardiology, biology, catheterism also. We have a lot of intensive care unit beds and 24 operating rooms for surgery and 8 for non-surgery. So it's a very nice hospital. What about the operating rooms? They are all similar. All the rooms in my hospital are similar, including care station inside software as a service for 12 rooms due to difficulty to connect the other rooms to the cloud. So only 12. Anesthetic station for all of the rooms with GE monitoring, including entropy and SPI, of course, and a ventilator for all the stations are IZCS2 with including head control, and all the data are recorded on the computer from the monitoring and for the drugs, of course. So I can work without any pain, without any paper. It's very important for us. And all the data, I can send all the data in secure cloud, for example. So, question today is probably what about outcomes for patient, what we want to do with the patient for the intra and post-operative period. Probably after major surgery, it costs a lot of money when we have complications, and you know that after major surgery, we can observe up to 20% of complication, including minor complication, pain, urinary retention, nausea, and vomiting. But there is a lot of very important complication at 30 days after surgery, including readmissions, respiratory adverse events, mortality, thrombosis, wound dehiscence, and also other complications. This will induce a high level of mortality, 2 to 3% in the laboratory. It depends on the site and the type of surgery, of course. In my hospital, the number of complications after major surgery is about 0.8, which is, I think, not so bad. Not so bad. Can discuss. So the question is now how to reduce mortality and morbidity. So there is probably 3 ways to reduce mortality and morbidity after surgery. First is to use better care pathway, including ERAS programs, of course, PREMS and PROMS, patients reported outcomes and experience. Second way probably is to use better surgical procedure, including non-invasive surgery, for example, robotic surgery, cystoscopic, and reduce incision and damaged tissue. And the third is probably improve monitoring and the way of you perform anesthesia, and probably adequate monitoring, including best practice for the anesthesiologist. Okay. So probably to implement a procedure, to implement new strategy for different practices, the best way is to perform feedback, because feedback drives progress, of course. And how to perform this? You know that no prophet is acceptable in his home country. So we have to produce data and to make feedback to the team, including first step, photography, the baseline of your practice. Second, perform educations, change your practice, and now perform a second evaluation, another photography of the practice. And this is a virtual cycle, but this is very interesting for a lot of people to work with this way. So we performed a large study published 2 years ago with this strategy for lung protective ventilation. And we performed for hours the same strategy to demonstrate the interest of use of AWA in our practice. So you know that depth of anesthesia monitoring and nociception monitoring play crucial roles in anesthesia care and patients' outcome during surgical procedure. This is the main point of this presentation. But question is how to integrate entropy, SPI, level of mean arterial blood pressure in your practice, and do you use entropy, SPI with very good thresholds and other parameters. So what about the literature for hypnosis, blood pressure, nociception, and curiarizations? You know that for hypnosis, monitor the brain, it's very important to reduce delirium and confusion after surgery, for example. For the anesthesiologist, there's first action is probably to reduce the MAC, for example, to reduce propofol target if too much important to high level. For blood pressure level, just show this slide, this picture. This picture represents the blood pressure, the different level of blood pressure, 40, 60, 80, 20, and the mortality after surgery. And you know, there is a relation, direct relation between the level of MAP blood pressure during the intraoperative period and complications after surgery. If you have too low blood pressure during surgery, you will increase the mortality after surgery. There's a very strong relation between the two. So probably to maintain blood pressure, you have to use vasopressor fluid to be sure that the target is more than 60. For nociception, there is some literature that demonstrated that too low nociception will induce chronic pain, acute pain, and so. And there is a trend for most of anesthesiologists to reduce the use of opioid during the intraoperative period. This is opioid-free anesthesia or opioid-free analgesia. This is a new concept. For curiarization, clearly a patient must be without any new neuromuscular block agent after surgery, because this will induce respiratory complications. So, if I summarize, now there is probably two situations. First one is for minor surgery, or and a lot of anesthesiologists, they just focus on heart rate, SpO2, and blood pressure. And now there is second situations for others, like me, not only to focus on these parameters, but to focus also to SPI entropy, and to maintain the blood pressure in very, very few ranges. Probably you know this picture from Van Gogh? Yes? No? Yes? So, it's very nice because you see different stars, probably lines, and the blue sky, of course. But if I say it's MAP, it's entropy, this is SPI, in practice there's no lines between. The link between these different stars, it's different to perform this in practice. So probably we have to link these different stars in practice in anesthesia. So I performed a big study using our care station inside, and the target of the study was to use MAP, train of 4, entropy, and SPI to be sure that the different ranges of the parameters was in the thresholds, in the good thresholds, and we perform a before-after study. The primary endpoint of this study was reduction of complications linked to PAM, entropy, and SPI. Of course. So start. First, we performed the study using method as described before, with first photography. This was the baseline of the cohort, of the population, of my population and my team. First, we perform education sessions, and third, we perform a new photography of the cohort to be sure that there was a reduction of complications and that anesthesiology used more and more entropy and SPI. Is it okay? Yes. Is it possible to do this study without our care station inside? I think no. Why? Just look on this case report. This is a case report for patients, a very long surgery, 6 hours with blood loss, fluid administration, norepinephrine use. It's difficult to see and to calculate the duration of hypotension, to calculate the duration of the level of low entropy. Manually, it's very difficult. So when you use our dashboard, you can automatically, with secure data, record all of the data for these patients and to look after what's happened. Okay? So what we do with our care station inside, step by step. First, we make a photography of the cohort of the patients and my team. For the patient, you must select the population to analyze. There's no reason to monitor patients for minor surgery, for ambulatory surgery. There is no reason to put on the head entropy and to be sure that SPI are in the good ranges. Probably you have to analyze subgroup populations with in-hospital surgery, major surgery, and high risk or intermediate risk of surgery. Okay? So, first, select the population. Secondly, set on our the monitor thresholds in our applications using strong recommendation from guidelines. There's strong recommendation for train of 4, but the recommendation for the level of blood pressure, of mean arterial blood pressure, is it 50, 60? It depends. So, for my institution, for train of 4, of course, there are strong guidelines. But for the mean arterial blood pressure, we decided to set the level of 60 and the duration of hypotension 5 minutes. You can increase or reduce the different levels. It depends on your institution and your team. But that's what we perform. Then you have to define outcomes for the patients, mortality, morbidity, what you want to observe for sevoflurane, also. Before to start the study, we assess my team knowledge for MAP, entropy, SPI, and TOF. What do you know for these different parameters? So we perform a large pre-test questionnaire for the residents, for the consultants, for the nurses, using QR code, of course. So this is what we observed. This was for the photography for the baseline. Here, before educations, 1 point, one anesthesiologist, and the score between 0 to 100, and the mean level was 72. After education, you show the number, 85. So the population of anesthesiology increased their knowledge for entropy and SPI. And the wrong answer was majorly for entropy. So next, so this was the first step of the study. We recorded more than 5,000 cases, major surgery from May to August. all the patients had eventually entropy, and we record on the dashboard the different levels and percentage of use of the patients. Then we perform also education, and step 3, the end of the study, the second part of the study, we record a new cohort of patients. 524 cases. This was between September and December. And the results. What are the results? So, you see here the number of case reports in the before step. Here's the number of patients in the second part of the study. This is the after step. So this was a before and after study. Between those two periods, the education program, of course. So for mortality, there's no difference between the two groups. There's 4 days, of course, no difference. Mortality, including major complications, there is no difference between the two groups. You see the percentage of the two groups similar with the literature. But what is very interesting, when you all focus on the different complications linked to the study, we can observe that there are 3 major complications that were reduced in the after study compared to the before study. So for hypertension and sepsis, for renal respiratory adverse events, for renal dysfunction, there was less patient with complications in the second part compared to the first part. Okay? And when you see the duration in intensive care unit after surgery, after major surgery, you can observe a reduction, no significant, but a reduction of days in intensive care unit in favor of after group. So interpretation of the study. We are looking to the MAP pressure for the study, the rescue of norepinephrine, the use of the 3. What are the 3? SPI, SE, and train of 4 for the group. The time in the good ranges for SE, missing data. So first, this is in French. In the after group, you see that the number of patients who are the percentage of patients between the two groups are different. Much more patients have higher blood pressure than the before group. The rescue of norepinephrine is higher, normally because the anesthesiologists have focused on the MAP and use more epinephrine. You see the difference. Okay, we had educations and now we use the monitor. You see? And second, there's much more anesthesiologists that are using entropy and the levels entropy in the before to after group. Okay? Just focus on the dashboard. You can observe the dashboard on the just here after. So in conclusion, first one, using our care station at site, this is a team project. And this is a quality monitoring with feedback. It's very important. You can drive progress using feedback. You can working towards goals with objectives. You can perform repetitive audits at any time. It's very simple to use it. We have secure data, no human action. It's very interesting. We can focus on different type of anesthesia. And finally, with the studies that I present today, we can say that probably this is a way to better care and to reduce patients' outcomes, probably. There are also a negative point today for this with this application. Probably the feeling of being spied, of course. But you have to say to the population of your team that it's not a spy. We are not spied. It's just an application to be sure that what we record are for the patients, in favor for the patients. You have probably to use this application, select patients and outcomes. And there is a trend of refractory to future practice, of course, but you have to explain to your team what's happened. And probably, I just show you part of the results of the study, and we have to consolidate the data now. Future for these applications, in my opinion, probably education is the major point for these applications, and probably with artificial intelligence, we can probably improve the link and predict intraoperative parameters to complications. But we have probably perform more link between the different stars of the monitoring, between entropy and SPE, and so. Thank you.